Hello again, Social Work Practice 1 students. Here we are um, starting on Chapter 7. We're in the Generalist Practice book. That's the hardbound textbook. We're talking about implementation now. Our learning objectives are going to be recognize child maltreatment, to examine the child protective services, to apply the generalist intervention model to practice in child protective services, to examine and implement crisis intervention, to provide disaster relief and trauma counseling, to work with and empower older adults, and to employ generalist practice in empowering immigrants. We're also going to address alcohol and other substance abuse. Implementation in generalist practice. That is the next step in the plan change process. It involves carrying out the actual intervention plan after engagement, assessment, and planning. It can be considered the actual doing of social work. Intervention encompasses treatment and other activities social workers use to solve or prevent problems or achieve goals with our clients. That's what we use to do that. We will find that special knowledge, skills, and techniques are useful when implementing an intervention plan. We're going to investigate several approaches that generalist practitioners commonly utilize to address problems in designated practice areas. The ones we're about to explore were chosen to reflect a broad range of practice issues and scenarios that we might encounter, that we would commonly encounter. We'll first discuss child maltreatment, then empowerment of older adults. Next, we're going to do crisis intervention, and then finally we'll conclude with alcohol and other drug abuse, AODA. When we're talking about what are our roles in child maltreatment, social workers have been historically involved in the detection, the assessment, and the treatment of child abuse and neglect. And it is an area of social work practice that several of you are likely to enter. And at least two of you I know of have talked to me about that's going to be your plans. Even social workers addressing other issues and serving other populations must have a sound knowledge and skill base to assess maltreatment's occurrence and make appropriate referrals. I recently had a client where I had to refresh my knowledge about what was and was not reportable. We'll discuss how to address child maltreatment using the generalist intervention model. There are a number of ways that children can be abused and neglected, and the umbrella term that is used to include all of them is child maltreatment. Child maltreatment includes physical abuse, inadequate care and nourishment, deprivation of adequate medical care, insufficient encouragement to attend school consistently, exploitation by being forced to work too hard or too long, exposure to unwholesome or demoralizing circumstances, sexual abuse and psychological abuse or neglect. Definitions used by legal and social service agencies vary from locality to locality and state to state. Usually all can be clustered under two headings: child abuse and child neglect. Child maltreatment is a critical issue for us as social workers to understand. We need to know the clues that signify maltreatment. Like I said, I recently worked with a young family, and they had a child, and I had to look up some stuff just to make sure that I wasn't witnessing something that I needed to report. Physical abuse is the non-accidental injury inflicted on a child, usually by a caregiver, an other adult, or sometimes an older child. A major issue involves the everyday fine line between physical abuse and parental discipline. When does discipline become abuse? Some cultures have customs or practices that child protection would consider abusive. The textbook discusses the Vietnamese culture and a practice that involves rubbing their children with a coin heated to the point that it leaves burn marks. And I don't know what I think about all that. But what do you all believe and feel about these customs? Should they be forced to abide? Should others be forced to abide by the laws of the culture in which they now reside, or should the laws be changed? For us as social workers assisting immigrant families, it would be important to understand their cultural values and approach the family in a non-blaming way when addressing how they discipline their children. When working with families, we'll need to be able to recognize the physical and behavioral indicators of child maltreatment. The physical indicators that a child is being physically abused can be broken down into 6 categories. That's highlight 7.1 on page 258 in your textbook if you want to follow along. Some physical indicators of physical abuse include bruises. Bruises on any infant should be suspect because the chances that they can bruise themselves is not likely. Bruises on any child that are in unusual places or have unusual patterns may be indicators. Bruises that look like a hand mark or a belt mark should always be noted. Bruises that display a variety of colors may be a sign of abuse because this may be an indication that a series of bruises have been received over time. Lacerations, cuts, scrapes, or scratches, especially if they occur frequently or their origin is poorly explained, may be an indicator of physical abuse. Lacerations on the face or genitalia should be noted. Also, bite marks may be abuse indicators. Fractures, bones, or any other skeletal fractures, especially if they occur frequently or if their origin is poorly explained, may indicate abuse. Strangely twisted fractures and multiple fractures can be telltale signs. Infant fractures are always suspect. So are joint dislocations and detachment of the thin membrane covering the bone, the periosteum. Burns are another physical indicator of physical abuse, especially ones that take odd forms or in patterns. They may indicate abuse. Burns can be from cigarettes or a rope where the child was tied and confined. Burns that occur on normally inaccessible portions of the body, such as the stomach, the genitals, or soles of the feet, are clues to abuse. Another indicator is head injuries that indicate abuse or skull fractures, loss of hair due to vigorous pulling, and subdural hematomas. That's where the blood has collected under the outer covering of the brain after strenuous shaking or hitting has occurred. Black eyes should be suspect. Another indicator is internal injuries. There could be such things as the child's spleen, kidneys, and intestines are injured due to hitting and kicking. After considering the potential indicators of physical abuse, some major questions that you can ask yourself if you think a child may have been physically abused are, does the child get hurt too often for someone their age? Does the child have multiple injuries? Do the injuries occur in patterns? Do they assume recognizable shapes? Or do they look like some of the injuries described, what we described in 7.1 that highlight? Are the injuries such that they do not seem possible for a child at that stage of development to have sustained accidentally? Do the explanations given for the injuries make sense? If something does not seem right or logical to you, it may mean something is wrong and it may be a clue to abuse. In addition to physical indicators of abuse, behavioral and emotional indicators provide another dimension of clues to physical abuse. A physically abused child often tends to adopt behavioral extremes, and it is the frequency and severity of these extreme behaviors that make them noteworthy as indicators of physical abuse. There are at least 6 categories of behavioral and psychological indicators noted in our textbook. One of these is developmental lags or delays. Because abused children are forced to direct their attention and energy toward coping with their abusive situation, these delays may appear in the form of language delays, poorly developed social skills for their age level, or lags in motor development. It could be poor academic performance. Could also be another indicator, such as poor school achievement and adjustment. Poor school adjustment. More need for special education services. They score lower on reading and math tests. They exhibit more learning disabilities and are more likely to repeat a grade. Sipping my coffee. Another indicator could be notable aggressive behaviors and marked overt hostility towards others caused by rage and frustration at not getting their needs met. Many physically abused children are so desperately in need of attention that they'll try almost anything to get it. Another indicator could be that the child is extremely passive or accommodating. They show submissive behaviors aimed at preserving a low profile and avoiding potential conflict with parents that might lead to abuse. These behavior patterns are sometimes referred to as hypervigilance. Another thing is they show difficulties in peer interaction. Physically abused children often have poorly developed social skills, so they have problems making friends and interacting appropriately with peers. They have Psychological problems such as depression, low self-esteem, and a sense of hopelessness. It's another indicator. Child neglect is okay, we're going to start talking about child neglect now. Child neglect is a caregiver's failure to meet a child's basic needs that may involve deprivation of physical, emotional, medical, mental health, or educational necessities. Child abuse involves harming a child through actions. Child neglect causes a child harm by not doing what is necessary. Neglect occurs when children are not given what they need to survive and thrive. There are 12 categories of neglect, and you can follow along with me on page 260. That's highlight 7.2. One of the categories is physical health care. This is illnesses not attended to or proper dental care not maintained. The next category is mental health care. Child's mental health problems are either ignored or left unattended. Sometimes caregivers refuse to comply with recommended corrective or therapeutic procedures in cases in which a child is found to have serious emotional or behavioral disorder. Educational neglect, that's another category. That's where parents or caregivers fail to comply with laws concerning school attendance. Excessive truancy and tardiness without adequate or appropriate excuses may indicate neglect. Supervision is another category. That is when children are often or almost always left alone without adequate supervision. Sometimes that's leaving children with children. Abandonment and substitute childcare is another category. That's when parents are leaving children alone and unattended, and that's when parents fail to return when they are supposed to, and they're leaving childcare providers in the lurch, not knowing what to do with the children. Another indicator of child neglect is housing hazards. That's housing with inadequate heat, inadequate ventilation, or inadequate safety features. Dangerous substances such as drugs or weapons may be left in a child's easy reach. Electrical fixtures may not be up to code and are dangerous. Another indicator of child neglect could be household sanitation. That may be food spoiled. The home may be filled with garbage or excrement. Plumbing might not work or may be backed up. Personal hygiene. Children's clothing may be ripped, filthy, or threadbare. Their hair may be unkempt and dirty. They may be unbathed and odorous. Nutrition. Children that frequently complain that they are hungry and searching for food may be victims of neglect. Children that are provided food with inadequate nutrition actually may be neglected. Significant delays in developing result from malnutrition may also be a clue to neglect. Problems with social interaction and attachment issues is also another indicator of neglect. Children may have problems interacting with parents and may fail to maintain secure attachment relationships. This is something that they've done a lot of studies on. They may also display problems with peer relationships. The children with attachment issues. Cognitive and academic deficits are another indicator. Children may exhibit language deficits, poor academic achievement, low grades, deficits in intelligence, decreased creativity, and difficulties in problem solving. Some research found that neglected children tend to experience greater cognitive and academic problems than physically abused children do. Emotional and behavioral problems are another indicator. Neglected children may exhibit indifference, withdrawal, and isolation, low self-esteem, physical and verbal aggression, difficulties in paying attention, psychiatric symptoms such as those displaying anxiety or depression. Emotional and psychological neglect is a passive lack of attention to a child's needs that includes inadequate nurturance, inadequate affection, refusal to provide adequate care, or knowingly allowing maladaptive behavior such as delinquency or drug abuse. This is all under emotional and psychological neglect. That is actually a category of neglect. And I'll start over with that. It's a passive lack of attention to a child's needs that includes inadequate nurturance, inadequate affection, refusal to provide adequate care, or knowingly allowing maladaptive behavior such as delinquency or drug abuse. This neglect also includes parents who are inconsistent, they're unresponsive, or insensitive to babies' cues and signals. This causes babies to learn that they cannot count on parents for care and support. This can leave lasting issues with that child. Another category is emotional and psychological abuse. Like other abuse is more It's more aggressive and negative than emotional neglect. It includes verbal and emotional assaults on the child. It's threatening harm or close confinement. This abuse involves purposefully belittling, humiliating, rejecting, undermining a child's self-esteem, and generally not creating a positive atmosphere for the child. Okay, emotional and psychological maltreatment encompasses both emotional and psychological neglect and emotional and psychological abuse. It is often difficult to separate the abuse from the neglect. Rather, this maltreatment involves a pattern of psychically destructive behavior. Some of the emotional and psychological maltreatment can be classified into the following 6 types. Spurning is the first type. That involves verbal and nonverbal caregiver acts that reject and degrade a child. Terrorizing is the next category, next type. It includes caregiver behavior that threatens or is likely to physically hurt, kill, abandon, or place a child or a child's loved ones or objects in recognizably dangerous situations. Threatening to kill your child's dog if they do not make the bed would be an example of that. Terrorizing that child. Isolating includes caregiver acts that consistently deny the child opportunities to meet needs for interacting or communicating with peers or adults inside or outside the home. Exploiting or corrupting includes caregiver acts that encourage the child to develop inappropriate behaviors such as destructive, antisocial, criminal, deviant, or other maladaptive behaviors. Denying emotional responsiveness or ignoring the child includes caregiver acts that ignore the child's attempts and needs to interact, failing to express affection, caring, and love for the child, and showing no emotions in interactions with the child. Mental health, medical, and educational neglect includes unwarranted caregiver acts that ignore or refuse to allow or fail to provide the necessary treatment for mental health, medical, and educational problems or needs for the child. Emotional or psychological maltreatment can result in low self-esteem, aggressive and antisocial behavior, substance abuse, difficulty relating to others, learning deficits, and physical problems linked to adequate health care. Okay, now we're going to change and talk about child sexual abuse. That is any sexual interaction between an adult and a prepubescent child. It also includes non-physical contact, such as exposing one's genitals to children or having children pose nude or stimulate themselves while being filmed or photographed. It does not matter whether the child is perceived by the adult to be engaging in the sexual act voluntarily. Because of the child's age, they cannot give informed consent, and it can only be considered as self-serving to the adult. Some of this content is going to be sensitive, and I'm going to apologize for that right now. Should have warned you about it up front. Incest is a form of sexual abuse between people too closely related to legally marry. That's often father-daughter, mother-son, brother and sister. Sexual abuse in families can involve blood relatives, but it's most commonly uncles and grandfathers and step-relatives, or most often stepfathers and stepbrothers. 4 categories of symptoms indicate that sexual abuse may be occurring. Physical problems that are indicators of sexual abuse in children include a small child infected with a sexually transmitted disease or with pain, bleeding, or bruising in genital or anal areas. Pregnancy is another indicator, especially if it occurs when a child is of an unusually young age to have sexual intercourse. Emotional indicators include depression, anxiety, low self-esteem, and thoughts of suicide. Increased or inappropriate sexual behavior. Sexually abused children tend to manifest behaviors such as overt sexual acting out towards adults or other children, compulsive masturbation, excessive sexual curiosity, sexual promiscuity, and precocious sexual play and knowledge. The sexual behaviors of sexually abused children are often associated with intercourse, such as mimicking intercourse and inserting items into the vagina or anus. These children show difficulties in social relationships. Sexually abused children are more likely to lack social skills and be less trusting of others. Other effects may include school truancy, running away from home, early marriage by adolescents. A large portion of homeless youth are fleeing parental sexual abuse. Incidents of child maltreatment. The actual number of child maltreatment cases is undeterminable, because all indications are that vast numbers of cases remain unreported. Characteristics of perpetrators of child maltreatment. We're just talking about overall child maltreatment. No one person may have all these problems. Each will likely experience some. We're talking about the actual perpetrators, not the victims. First, the perpetrators are most likely have serious needs for support and nurturance that remain unfulfilled from their own childhoods. Because their needs were unmet, they're unable to meet the needs of their own children. Second problem, characterizing abusers involves social isolation. Their own self-confidence is low. They fear rejection, so they do not try to reach out to others, which also means they have no one to help them cope. Communication and relationship difficulties are common. Communication is usually difficult, hostile, and ineffective, and the relationships they have with others are often stormy. Children may become easy targets for parents who cannot communicate with each other. They may direct their violence and anger at their children that is meant for their spouse. Abusers also do not know how to raise children in a nurturing family environment because their own family of origin may have been hostile and abusive. They could not learn what they were not taught. Other characteristics of perpetrators is they may have poor coping skills, which means they are unable to cope with stress, so they're lashing out at their children instead. They may lack anger management skills. They may not have learned to separate their feelings and emotions from their behaviors. Therefore, when they get mad, they do not talk, they hit. There's also a tendency to blame others for their mistakes. They may lack decision-making and problem-solving skills that are necessary in coping. Other coping skills abusers fail to master is how to delay their own gratification. The here and now become all important. If the child misbehaves, a kick will take care of it immediately. If their stress level is too high, they may need immediate relief with no regard to what the consequences of their behavior will be in the future. Extreme external stress and life crisis also are characteristics of perpetrators. Poverty is one thing that causes stress. Feeling isolated and incompetent. The loss of a job, illness, marital or family relationship dispute, or a child's behavior problem may push people over the brink so that they cannot cope, and they take out their stress on the easiest and most available targets, which are their children. Neglectful parents have similar characteristics as physically abusive parents, although poverty can also contribute to the potential for neglect. The lack of resources creates an environment of stress, a sense of demoralization, and often depression, and a lack of hope. And when these conditions occur, the child's chances at a positive living environment decrease. One description of a typical neglectful parent is an isolated individual who has difficulty forming relationships or carrying out on the routine tasks of everyday life. They are burdened by anger and sadness over their own unmet childhood needs, which makes it impossible to consistently recognize and meet the needs of their own children. Unlike how an abuser lashes out, a neglectful parent withdraws and fails to provide adequately for their children. There's no clear-cut description that characterizes people who sexually abuse children other than the majority are heterosexual males who often know the child, usually in a trusting relationship. They tend to have poor interpersonal skills and low self-esteem. They're often more religious and conservative than average, and they're less knowledgeable about sexuality. Child maltreatment and child protective services are what we're going to start discussing right now. And I'm going to get a sip of water. I should have told you up front that this is going to be a pretty long lecture. There's a lot of stuff that we're covering, and I hope you can just hang on with me. You got lots of options to pause and start over, so. Okay. Child protective services are those involving assessment interventions by social workers and others in situations where children are deemed at risk of maltreatment. Protective service workers are usually employed by public departments of social services or law enforcement agencies and courts addressing the problem. The worker's major aim is to determine whether abuse is occurring, assess both strengths and risks involved in the family situation, make plans to ensure safety and minimize future risks, and implement plans to maintain healthier family functioning. Child Protective Services is characterized by the family preservation philosophy. The family preservation philosophy is about empowering families. Family systems-based philosophy emphasizes the importance of the entire family's interaction with each other and the environment, and guides the intervention to include all family members, not just the abuser. Trend in protective services involves home-based services and an intensive family preservation philosophy and approach. This approach targets vulnerable families by providing services to improve family functioning and to prevent out-of-home placement. It also involves the concepts and principles concerning what is important for intervention in cases of child maltreatment and for how practitioners should proceed with the intervention. A significant principle of the family preservation philosophy concerns the importance of the child remaining within their own families if at all possible. Another concept is that interventions are considered positive, especially when crisis occurs, so that children need not be placed out of their own homes. People are considered capable of changing if they have help. Okay. A philosophical perspective on family preservation emphasizes 6 points. First, the problem is seen as a social issue. Child maltreatment is more the fault of a difficult and unsupportive environment than the intentional deeds of particular parents, meaning that successful family life can only occur in communities that are concerned and supportive and have resources that offer opportunity and hope to residents. The focus is on the environment and the parents' interactions with that environment. The second principle involves the worker taking a partnership role with the families and be helpful to ensure that the parents become stronger and more effective. And that's an empowerment perspective there. The third principle is that we assist families in coordinating their intervention efforts with other professionals who can also help the family. And this is case management. We do not have to and often cannot do everything for the family ourselves, and often we can be more useful by overseeing and integrating the work of others. Case management. Remember, this philosophy is positive. The fourth principle indicates that maltreating child caregivers can improve their conduct, meaning they can change with support and assistance. The fifth principle offers the guidance that keeping maltreated children within their own families, if at all possible, is best as long as the children are safe. This principle relates to the idea that risk can be minimized and the children's safety maximized if internal and external pressures can be controlled and parents are taught coping strengths. The sixth principle is that clients should be integrally involved in the intervention. We support parents and capitalize on their strengths in this way. A cautionary note regarding family preservation. If it is determined that the risk is too great to children's safety and that they have to be removed in order to keep them safe and well cared for, the protective services worker has the responsibility for identifying, considering, and weighing factors that affect the child's safety, permanency, and well-being. Children's safety and their need for nurturance guide the actions of child protective services workers. It is also important to keep in mind the important related concepts of permanency planning, which is the process of establishing a long-term placement plan within a reasonable time frame in the event that placement with the family is deemed not possible. As with other aspects of social work, protective service workers follow the plan change process by the general intervention model. Remember, this is what we keep talking about, and right now we're talking about implementation. We're going to start with the model right here with engagement with child protective services. It's especially critical in child maltreatment cases because engagement is like, imagine when a social worker shows up on a family's doorsteps. What feelings might that family feel because we show up at their door investigating possible child maltreatment? Anxiety, discomfort, guilt, shame, defensiveness, anger, resentment, resistance, opposition. They're all likely common feelings that they're going to be exhibiting. So it's going to be up to us as the workers to diffuse all of these negative emotions and reactions. We should attend to the child and the entire family's emotional and psychological needs when we do this. That's the engagement part of it. During assessment, the worker, we, should interview and observe the behaviors of the children and the parents to identify clues that suggest child maltreatment. Then we have to assess the degree of risk to the child for if they stay in the home. Approaches to this are done by interviewing the child, appraising the family system dynamics, and evaluating the forces that contribute to the risk. When interviewing the child, we have to be aware that the child's perceptions might differ from that of the adults. One recommendation is that we listen carefully to comprehend on many levels what the child means when they say means to say, because often they use stories and metaphors representing what they want to say instead of using literal facts as adults do. Another difference in children's perception of time is their perception of time. We may need to refer to milestones such as what time they got up, or how long it is before Christmas, or something like that your child understands, because they really may not have a perception of time or dates. The third thing to be aware of is that a child's attention span is usually more limited than ours, than adults. Another suggestion to pay attention to is the interview setting. And try to select a space that's familiar and where they feel comfortable, or in someplace private if possible. Be sensitive to a child's emotional perspective in view of the turbulent context of the situation, of the abuse. It may be difficult to get the child to trust due to the hurt that was inflicted upon them. We want to introduce ourselves to the child and inform the child about the purpose of the interview, what our role is, let them know what our role is there, that we're there to help them, that we maybe start with some small talk, let them know that we work with children, that we try to help children, that's what we're there for. We may need to use small talk about the child's toys, talk about some television shows, talk about what they're wearing, and then maybe help them talk about what to anticipate in the future. In addition to getting information from the child, it's also important to obtain an accurate understanding of the family's circumstances. Questions should be focused on the forces of the risk. Try to get details from the family, such as times, dates, and specific incidents that can be discussed, along with why the worker and their agency and the family can be concerned about the issues. Another task during the initial assessment is risk assessment. And this is the process of determining the degree of risk for children and the need to further involve the family with social services or law enforcement. Risk assessment is future-oriented in that it aims to predict the potential for maltreatment in the future. There are two primary purposes for risk assessment. One is to maximize children's safety within their environment. The other is to change and control those forces that act to increase risk within that environment. A child has greater safety when stresses impinging on the family are minimized and family members have been strengthened to better ward off such stresses in the future. It is the protective services workers' responsibility to assess how much at risk a child is for potential maltreatment. There's 5 forces that contribute or diminish risk in a home. Maltreatment force is one of those. It's the first one. It involves the type and severity of maltreatment. Are children being neglected, burned, beaten, or sexually molested? And under what conditions does the maltreatment occur? Is the abusive parent drunk, depressed, or explosive? Does the maltreatment occur randomly or only in times of crisis? Child force is another one. And it involves the maltreated child's personal characteristics. How susceptible do we as social workers perceive the child be to maltreatment? For instance, very young children and children with disabilities are particularly vulnerable. Parent force, that entails the characteristics of the parents in the family, such as how do they feel about themselves? Do they feel guilty after maltreatment occurs? How does each parent cope with external stresses? What kind of child management skills does the parents possess? To what extent does each parent rely on physical punishment to control the child? How does each parent interact with the children, and how responsive is each parent to the child's wants and demands? Another facet concerns the parent's own upbringing and past experiences. A final facet of parental force is the interactional patterns of the parents with others. Another force that contribute or diminish risk in a home is the family force, and that it concerns 3 elements. One is the demographic variables that characterize the family. Are one or both parents involved? How many children are there? Is the family blended with step family? What levels of education, job training, and work experience do parents have? What is their income level? Is unemployment a problem? What are the housing conditions? The second facet of family force involves how the family can function, interact, and communicate. And the third facet of family force is the overall support and nurturance the family receives from the surrounding social environment. And the final force that contribute or diminish risk in a home is the intervention force, and that concerns our anticipation of how the family will react to the intervention. Will they be wary, angry, or afraid? It also involves the outside pressures on the family that might hinder the intervention process with the family. Now we're going to move on to the planning step of the intervention process, plan change process with Child Protective Services, and that is when the planning is when the objectives are specified, responsibilities assigned, and the who will do what by when process is clearly established. There are at least 8 dimensions upon which goals are frequently based for families and risk management. The first is self-sufficiency, and this means that the parents and families must enhance their ability to function independently. The objectives may include increasing self-esteem and confidence. The next is communication skills. Improvement is a common goal. Communication skills improvement is a common goal among family members. That's one of those 8 dimensions, which goals are frequently based for families and risk management. Parenting knowledge, because parents may not know how to handle and control children. They can be taught not only to control but also to play with and enjoy their children. Parents may need knowledge about normal development. They need to know what to expect in terms of normal behavior at each age level. Another one is stress management. That can be taught so that parents can better manage their stress levels. They can be taught to release their feelings more appropriately instead of allowing emotional pressures to build up and explode. Learning stress management techniques can also help them cope with stress. Another dimension of goals is poor impulse control is something that parents and families at risk often have. And they need to learn how to direct their energies in more fruitful ways than violently lashing out at their children. Problem-solving skills are another common goal area. And that's something that parents need to learn so they can analyze problems, translate problems into needs, establish potential alternatives to meeting these needs, evaluate the pros and cons of the alternatives, and select and pursue their most promising options. Interactive nurturing is also another one. That means family members need to be taught how to both express their positive feelings and accept affection. They can be taught how to empathize with each other, verbalize their feelings, and reinforce their support and caring for each other. Resource enhancement is also another area. That means that increasing a family's resources also increases a family's strengths. Also, when we're talking about Child Protective Services and plan change, implementation is the next step. And that's the intervention specified in the plan or carried out during this step, which includes tasks for the worker, tasks for us, the client family, and other professionals involved in the case. It is likely that we will function as a case manager in this area, the one who coordinates a range of services during this part of the intervention. The next steps are evaluation, termination, and follow-up. During these steps, workers document progress, they review goals and objectives, that's what we're going to be doing, and amend intervention plans to meet the current risk situation. The case is terminated when the risk has been determined to no longer be present or has been significantly decreased so that the children are adequately safe. Follow-up can be used to determine the risk conditions at some time in the future. Empowerment, child maltreatment, and practice with families and groups. That means because the worker is with a family, principles involving how to work with groups are necessary here for us as social workers. We may need to link abusive parents with support or child behavior management groups or support groups for survivors of child maltreatment, both as children and adults. That's another possibility for us there. Empowerment with child maltreatment and practice with organizations and communities. As social workers, we might pursue improvements at the macro level in at least 5 areas. We should focus more efforts at prevention, gearing more services toward improving resources and services for families, gear more services towards treatment instead of case finding, focus more on treatment outcomes and improvement rather than on treatment process. And lastly, more community and neighborhood support should be located and developed. And that's if we're want to talking about empowerment and child maltreatment and practice in the macro area, the macro level of practice. Now we're going to move on from child maltreatment, and now we're going to talk about crisis intervention, which means I need another sip of coffee. strategy of crisis intervention is a brief and time-limited therapeutic intervention where a social worker or other mental health professional helps a client's system in crisis recognize the precipitating problem and identify potential coping methods. Crisis intervention helps people learn to cope with or adjust to extreme external pressures. We use the term crisis in two ways. One is the internal emotional distress on the part of an individual or family experiencing such events as a death of a loved one, job loss, or unwanted pregnancy. Second is that it may be a social event in the macro environment, causing disaster and major disruption of life for a large number of people. Virtually any upsetting event can evoke a crisis. The crisis process means that crises typically progress in the following manner. First, the individual is exposed to a heavy amount of stress over some period of time. Second, the stress acts to make the person exceptionally vulnerable to intimidation and assaults from outside, which allows the third aspect, which is some precipitating incident which triggers the client's crisis state, characterized by instability, ineffectiveness, and inability to take action. The individual perceives everything as increasingly serious threats and experiences surging anxiety along with the depression and grief. Major concepts in crisis intervention. In this case, if you want to follow along with me in the text, here we're up to highlight 7.3 on page 271. Common themes in crisis intervention include the primary goal of crisis intervention is to help the person return at least to the pre-crisis level of functioning. Crisis intervention is relatively short-term. Specific, current, observable difficulties are the target of the intervention. Crisis intervention focuses purely on the crisis and those aspects of the client's life directly related to the crisis. It won't be anything else but about just truly focusing about what led up to the crisis, what's going to happen because of the crisis, and the actual crisis itself. The specific, current, observable difficulties that are the target of this intervention here, the crisis intervention. Crisis intervention strategies generally work better than any other approaches when dealing with crisis. Crisis intervention is a well-defined, viable approach that is indeed the best approach to crisis situations. They've been tested, they've been proven. The practitioner in crisis intervention assumes an exceptionally active role. We're going to be very active when we're working with individuals that are experiencing crisis, and we may be more directive than that assumed in any other approaches to generalist practice. Meaning that we may have to be, we're going to have to expend some energy to get the client moving from their emotionally frozen position. We may be more direct. We may have to do a little bit more of the telling them what to do because we know what to do. We've worked in this area. We've experienced it. So we may have to be a little bit more direct as opposed to allowing the client to take their time because we're needing to act fast. Steps in the crisis intervention. There's a clearly defined 5-step crisis intervention model that coincides with the plan change process in generalist practice. Step 1, sounds familiar, engagement. The foundation of crisis intervention is the development of rapport. It's going to have to be fast. You're going to have to develop rapport with that individual pretty quickly, and they're going to have to trust you. A state of understanding and comfort between the client and the social worker, meaning trust and openness, follow, allowing the interview to proceed. Have to develop all that first, that rapport. The next step is assessment. That's the art of the crisis intervention, is to focus on the specific precipitating event that brought the client to you. Only clearly related aspects of the client's situation should be addressed. At least 5 specific areas of questioning should be pursued. 5 and 5. Okay, so on step 2, we're going to go down to these 5 specific areas of questioning. First, determine why they called or why they came to see you on that particular day. The intent is to identify and specify as soon as possible what the crisis is. Second is, how does the client view the crisis situation and precipitating event? Find out how they perceive it. Third, involves whether the client has access to support from others. We need to already find out what support does this client have. Crisis intervention may involve others, and the more support you can muster in helping your client return to the pre-crisis level of functioning, the better. Fourth area to pursue concerns the client's history of solving similar problems. Can any of those coping skills be applied to the current situation? The fifth and very critical area of information to solicit in crisis situations involves the extent to which clients are in danger of harming themselves or others. If you determine that your client is seriously considering violently harming themselves or others, you may need to take more drastic steps. Okay, we're going to move up to step 3. This is the planning phase. This is when you must evaluate the extent to which the crisis has interfered with your client's ability to function. Also, it is when you review potential alternatives, evaluate the pros and cons, and determine the course of action to pursue. Reviewing strategies that worked in the past and deciding whether they might not be useful again is important during this phase. If a client's used something in the past, then they may be able to use that again. Find out what strengths they already possess. Step 4, that's the implementation and intervention. That's what our chapter's about. That's any variety of helping techniques that can be used in crisis intervention. Here we have some suggestions here for what to address during the implementation phase of the process the book told us about. First, we want to help the client look at the crisis more objectively. When people are in crisis, it's difficult to think clearly and objectively, meaning take some emotions out of it and look at the actual what's going on. We're going to help the client explore and express hidden feelings about it. We're going to identify and use coping approaches used in the past for resolving crisis. We're going to use that. That's common. It saves us a little bit of work. If they can tell us what they've done before that they've been able to utilize, that gives us something to work with right there already, and gives them something to work with right there already. We're going to reestablish old or develop new social support systems. People in crisis need as much social support and nurturance as possible. Step 5, we're going to go on to step 5 now, and that's planning for future crises. This helps clients prepare for any forthcoming events. The final phase focuses on articulating and summarizing what clients have learned during the crisis intervention process. And one of our tasks is going to help clients clearly identify and articulate coping behaviors so that these skills are more readily available when they need it, if they need them in the future or when they need them in the future. Planning for future phase of crisis intervention includes the evaluation and termination steps of the plan change process. Due to the fast nature of crisis intervention, all this stuff closes together and moves really quickly. These phases are accomplished quickly, and because of the nature of the crisis intervention, follow-up is not always possible or something that we would do. There is a case example in the text that you can read about someone dealing with the tragic sudden loss of a husband. That's on highlight 7.1, and it's about helping people cope with grief and loss. It's really good. You can read it if possible. It's 7.4. Okay, now we're going to continue on with crisis intervention. We're going to talk about crisis intervention with families and groups. Crisis intervention is relevant with families because it can be used to help the entire family when one family member experiences a disturbing event or when the entire family system suffers a disruptive crisis. Crisis intervention with organizations and communities is frequently utilized in response to crises involving major population groups suffering from natural disasters, wars, bombings, and terrorist attacks. At the macro level, disaster relief and trauma counseling. The disasters at the macro level are terrifying, devastating, and these days disturbingly anticipated. They may be caused by nature, human error, or terrorists, and results may include shocking injuries or loss of human life, extensive destruction of property, and displacement of thousands. I feel like we're kind of living in something that may be similar to that right now. I think a lot of us may be experiencing some of these things, and we kind of have to be aware and tune into ourselves about this. This is kind of scary for a lot of us. We don't know what's going on. Every day is different. Every day is unpredictable. So I think that, we maybe need to be thinking about, if we're experiencing trauma ourselves, about if we need to be reaching out to others. Really keep that in mind. So we're going to talk about assessment and disaster relief now. The first step is triage. That's the quick assessment of severity and scope of need. The urgent health and medical needs should be evaluated. People's survival is paramount. Survivor psychological functioning in terms of their stability and decision-making ability should also be assessed. Victims are likely to experience overwhelming distress, grief, and anguish. Data gathered should include essential demographic information, the perception of magnitude of the traumatic event, the coping methods, any presenting problems, safety issues, previous traumatic experiences, social support network, drug and alcohol use, pre-existing psychiatric conditions, suicide risk and homicide risk. Psychological triage assessment refers to the immediate decision-making process in which the mental health worker determines lethality. That's the extent of danger to life and health, and whether a referral to a hospital, an outpatient treatment agency, or social services agency or support group is necessary. When we're talking about intervention and disaster relief, the early intervention phase usually occurs within the first month following the disaster. In addition to assisting with the basic survival needs, other requirements may include communicating with family, friends, and communities, the need for orientation to disaster services and additional sources of support. It is also essential that information and referral services be provided so survivors can access the information and services they need. The first responders to a disaster also require support. They require encouragement and a chance to vent their frustration and horror at witnessing the disaster. Immediate crisis counseling is the standard protocol for responding to community traumas. Social workers can use their helping skills here. We're needed. We're going to be needed, y'all. Individual and group counseling can be provided. There are at least 8 basic tasks practitioners should undertake while working with disaster survivors and the loved ones of victims and others traumatized by the event. This is kind of going to go along with a plan training process in a little bit, because welcoming, that's engagement. That's where they're going to be building rapport. That's the first basic task that practitioners undertake while working with disaster survivors, is building that initial rapport. And this can be done with introductions, storytelling, icebreakers, or expressions of care and concern for the client and the community. Framing is the next one, and that entails framing the traumatic event in a meaningful language that makes sense to the individuals and the community. The goal is to understand what happened so that the distorted information about the event can be reduced and the facts surrounding the event can be clearly communicated. Educating is next, and that involves providing information about the common effects of trauma, such as numbness and fatigue, irritability and fear. The difference between stress and trauma should be emphasized, and coping strategies should be explained. Grieving is the next basic task practitioners should undertake when working with disaster survivors and the loved ones, victims, and others traumatized by the event. Grieving involves exploring what has been lost and what such loss means. Feelings have to be brought into the open so they can be dealt with, so ways to deal with the loss can be identified and means to continue living can be developed. Integrating goals is to create new possibilities for transformative ways of living following the trauma, and this can be done by asking questions about the event and what it means to a survivor. Reflecting is the next task, and that concerns exploring and identifying survivors' feelings about the community and what should be done to return it to health. Empowering is the next one, and that involves identifying the most effective and efficient tasks that will facilitate healthy outcomes following trauma. It also involves planning ways to obtain the necessary resources to complete these tasks. Terminating and revisiting is the next task, that involves summarizing what the individual or group counseling process has achieved. And we're still talking about crisis intervention with organizations and communities. We're talking about provisions of long-term help. Communities often experience 4 phases following a disaster. Heroism phase is first, and that's where helpers rally to respond to the crisis and help those in need. Second is the honeymoon phase, and this is where people work together to begin rebuilding their community. A high level of hope and optimism about building a better future. About building a better future is often present during this phase. The next is disillusionment. That's the third phase, and this is where the burdens of accessing adequate resources and trying to rebuild become extremely difficult and frustrating. The fourth phase is reconstruction. This is where the community residents take on the long-term grueling task of rebuilding as best they can. Social workers may work with disaster survivors for years after the disaster is over. They may continue to provide counseling and problem-solving assistance. They may also persist in linking survivors with needed resources. Another thing to take in mind is taking care of yourself in disaster relief. This is important, and disaster work is not for everybody. Some tips in the text to cope with resulting stress from disaster work include: get information about the extent of the disaster's magnitude and emotionally prepare yourself. Look at the task at hand. They should be the immediate focus with the work broken up and doing small jobs first. We need to use stress management techniques to maintain emotional control. We need to acknowledge our own physical and emotional limitations. We need to seek out and use peer support for strength. We need to vent emotions and to share our own distressing stories. Our role in disaster relief: since 9/11, there has been a call for more organized and extensive training of social workers in disaster relief crisis intervention. Okay, we're going to now move on to practice issues with diverse groups and social work practice with older adults. There are a wide range of issues facing this population, and we may have to assume multiple roles to address their diverse needs. An empowerment approach can help older adults emphasize their strengths and use them for competent problem solving. Empowerment focuses on engaging older adults in actions to improve their lives and empower themselves. Spirituality and religion as potential sources for strength for older adults. Spirituality can provide hope, peace, and a soul-searching sense of life review for older adults. Religion for older adults can be an outlet for emotional support and for a wide range of tangible services. Assessing an older adult's spirituality starts with how they describe their feeling about spirituality and religious affiliation. Spirituality can provide a powerful source of peace and understanding for older adults. But there are 3 reasons that we should use caution when addressing spirituality with older adults. One is to not assume that older adults have strong spiritual beliefs, because they may not, and they may not want to discuss it. 2 is we can never proselytize or try to convert older adult clients. 3rd is to use caution when discussing spirituality or religion with any client experiencing a mental disorder, because they may find these discussions disturbing. Terms used for older adults: older persons, or older individuals is what we commonly use. Try not to use the term elderly, because it is more of a description than an actual noun. The elderly. People are elderly, and they're not the elderly. Potential aspects of decreased power is something that we have to think about when we're working with older adults. Physical health tends to decline as people age, and decreased power is related to health concerns. This includes functional limitations and subsequent reliance on external support. The likelihood of experiencing limitations in the activities of daily living, the ADLs, the activities of daily living, increases also with a person's age. Another aspect of decreased power in older adults involves participation in the workforce. Older adults are faced with myths and stereotypes that disenfranchise them from the labor market. A final aspect involves the economic status of older adults. There is diversity in this economic picture, but there is a significant inequity with older adult women and people of color. They're more likely to be poor. There are 4 essential concepts in empowerment of the older adult population that the book discusses. That's adaptation, competence, relatedness, and autonomy. As workers, we'll need to focus on assisting older adults in adapting to new experiences and issues and losses. Empowerment achieves this by emphasizing how older adults can use their strengths to survive and adapt. Next, we as workers help older adults focus on what they can do and not what they can do no longer. We do this by emphasizing appreciation for their own level of competence. 3rd is relatedness, and this is where we as the worker assist older adults with a sense of belonging relating to other people by working to strengthen their relationships with others. Autonomy is the 4th concept, and this is when us as workers, help older adults live as independently as possible. Okay, some strategies for working with older adults. Because they are a diverse population, which are particularly vulnerable, older adults require special sensitivity and understanding. There are at least 5 strategies for workers to increase sensitivity, for us as workers to increase our sensitivity to older adults and to enhance effectiveness. First, to identify and face preconceived notions and stereotypes about older adults. We need to think, do we have any of these stereotypes and preconceived notions about older people? Oh, this is Violet. This is one of these noisy dogs that you keep hearing out there. I just had to introduce her to y'all. This is Violet. Try not to be so noisy. Okay. Where was I? Because they are a diverse population that is particularly vulnerable, older adults require special sensitivity and understanding. Okay, we're going back. I remember we were about preconceived notions and stereotypes that we have about older adults. We have to recognize those, eliminate, and change them. Next, we need to appreciate the different life situations experienced by people from different age groups within the senior population. They do have lots of experience, and we can learn a lot from them. Third, understand that they're individuals with unique characteristics, experiences, and personalities, just like anybody else. Fourth, we need to learn how gender and cultural background influence the aging experience. The fifth suggestion concerns understanding the developmental aspects of later life, such as people's physical, mental, living, and socioeconomic conditions. Okay, when we're talking about empowerment and work with individuals who are older adults, that's on page 286, highlight 7.7 in the textbook with me. And that identifies 6 specific empowerment strategies for working with older adult individuals. One, we have to listen carefully to what they are saying and work to understand what they mean. We have to help clients, that's number 2, help clients identify their coping skills and their abilities to implement planned change. 3 is to play clients recordings of other older adults talking about how they have learned to cope with similar issues. 4 is to share newspaper articles, stories, or other informative materials with them, especially about how older adults are engaging in service activities and political action. Number 5 is to connect clients with other older adults for social support to combat social isolation. And number 6 is to encourage clients to help others. Okay, when we're talking about empowerment with older adults and families and groups, support groups, strengthening and nurturing family relationships both can provide strength and support to older adult clients. If you can get them involved in the support group, that's always helpful. Also, support groups for people providing care for older adults can help invigorate the caregivers and indirectly support older adult clients. So if we can get our caregivers into these support groups as well, that's like a double way to help that older adult client. Respite care is when temporary relief is provided by assuming the responsibilities by someone else. That can also be provided for a family members caring for older adult relatives, that respite care. Empowerment with older adults in organizations and communities are macro level empowerment for older adults. And we can become involved in advocacy efforts for this population. The issues include defending the rights of older adults, providing adequate choices in areas such as housing and healthcare, enhancing accessibility to services, promoting wellness, and providing culturally competent services. Working to improve community services for older adults provides other important macro practice possibilities also. We're still talking about practice issues with diverse groups, but now we're going to swap over and talk about immigration status issues in social work practice. Immigration status is a person's position in terms of legal rights and residency when entering and residing in a country that is not the person's legal country of origin. There is a fundamental distinction that I think we should understand. Immigrants leave their country voluntarily, whereas refugees are fleeing because they have been forced out of their countries because of human rights violations against them. Legally, anyone who is not a citizen of the United States is an alien. An immigrant is a person who has been legally admitted into the United States and granted the privilege to be a permanent resident. A non-immigrant is a foreign-born person who is in the United States temporarily. A documented alien is one who has been granted a legal right to be in the United States. An undocumented alien is one who does not have a legal right to be in the United States. They're also referred to as an illegal immigrant or a deportable alien. A term closely related to immigration status is national origin. which involves individuals, their parents, or their ancestors' country of birth. Many immigrants may need social services and help in adapting to their new lives because they will often find it difficult to integrate into the mainstream culture. Finding employment, accessing adequate housing, and fitting into the social fabric of neighborhoods and communities can be difficult. Social workers need to be skilled practitioners to work with diverse clients traumatized by poverty, discrimination, exploitation, war, famine, violence, genocide, violence, and a wide range of physical and emotional problems related to leaving their homelands for a strange and too often hostile environment. Okay, on page 289, highlight 7.8, if you were following me in the text, it's about critical issues in working with people having another national origin. The text offers 6 special issues to address when working with people having other national origins. The first is cultural heritage. A social work goal is to help immigrants and refugees adapt to their new country without leaving behind their cultural customs and traditions. Another is maintaining ties with their country of origin. We need to try to assist in however way to help immigrants and refugees maintain contact with people they left behind in their country of origin. We need to also help with linkages with ethnic communities. One way of maintaining cultural ties is participating in community activities and support systems with other immigrants and refugees from the same or similar nations. Language is another special issue, and that's where social workers, we should take responsibility for providing services in the language requested by the client. Learning about the U.S. system is another one, and that's such as the policies and services and the legal system. Advocacy is another way, and that's where we much more can be done to provide responsive and adequate services to immigrants and refugees, people who migrate here illegally and are especially susceptible to service deprivation because they fear deportation if the system finds out that they are here. So we're going to move on over now to completely change the subject, and we're going to move on to alcohol and other substance abuse. Oh my goodness. That's a lot. I told you it was a long lecture. We've already gone over the hour mark. I bet you've paused many times. Okay. We need a background in substance use and abuse, also referred to as alcohol and other drug abuse, AODA, for 3 basic reasons. First is that we may be employed in agencies specializing in treatment for substance abuse. Second, knowledge of substance use and abuse, even when not providing services to direct clients, is necessary for social workers with graduate degrees because we may serve as agency administrators, policy analysts, and planners, and consultants to planning groups or legislative aides. The third reason for needing some background is our role as a referral agent or broker. We will have clients or family members of clients with alcohol and other drug problems, and we must be capable of making appropriate referrals. Alcohol and drug abuse is often masked by and interrelated to many other problems that we will deal with, regardless of practice setting. We will likely need to address substance use problems. There are many similarities between alcohol abuse and other drug abuse in terms of biological, psychological, and personal implications. If you want to look on page 291, 7.9, the highlight definitions of AODA terms and concepts, and also 7.10, page 293, and that's the role of a referral agent. If we conclude that alcohol or other substance abuse is a problem for a client, we will need to know what resources there are available to help them. Some of the resources include detoxification, and that's the short-term treatment designed to oversee the client's safe withdrawal from the substance to which they are addicted. Not safe. To oversee the client's safe withdrawal from the substance to which they are addicted. Outpatient treatment is that received by clients participating in a program without staying overnight at a treatment facility. That's just day treatment. Inpatient treatment is that received by remaining at the facility all day and all night. Therapeutic communities are residential programs where clients remain from 1 to 3 years. Halfway houses are temporary residences to assist in the transition from an inpatient program to the real-life community. And then there are mutual self-help groups that are composed of non-professional members who voluntarily gather together to provide mutual support, talk about shared problems and concerns, and help each other to improve their lives. The text discusses AA more in depth on page 293, highlight 7.10, if you want to look into that. People with alcohol problems. Alcoholism is a chronic disorder characterized by repeated excessive use of alcoholic beverages and decreased ability to function socially and vocationally. An alcoholic is someone suffering from this condition. Alcohol abuse is complex, and alcohol use disorders develop over time. Alcohol problem has been suggested as a better term. Alcohol problem has been suggested as a better term for alcoholism. If someone's drinking causes problems with their health, finances, the law, work, friends, or relationships, then that drinking is problematic. If it causes problems for spouses, children, parents, bosses, or subordinates, then that drinking is problematic. Problems arise for those people who lose control of their consumption and become increasingly dependent on alcohol's effects. Each individual responds differently to alcohol dependence in terms of severity of physical and psychological effects and the length of time it takes to become dependent. So everyone varies on that. People who abuse alcohol or other drugs typically adopt a series of defense mechanisms to protect themselves from having to deal with the problems caused by abuse. One of these is minimization. This means assigning little importance to drinking or its consequences, saying something like it's not so bad. Rationalization is another defense mechanism. That is when they make excuses for the problems caused by the dependence on alcohol. It's been a rotten day. I deserve a drink. I didn't flunk that social work practice 1 exam because I had a hangover. Professor James made those questions much harder than he said he would. And lastly is denial. And that involves insisting to oneself that there is no problem, distorting reality in such a way that they do not see the truth. I don't really have to have a drink. Numerous social and relationship problems result from alcohol and other substance abuse, including marital and family difficulties, disruptions in friendships, trouble in work and social performance, accidents when operating vehicles, and being arrested for crimes committing while under the influence. Alcohol or another substance of choice becomes the abuser's best friend. It is something that they can depend on, and the effects are pleasantly predictable, and the abuser can escape from life stresses whenever they want. Now we're going to talk about alcoholism in the family. Alcohol abuse and dependence are family systems problems. That is, the problem affects the entire family. What happens to one family member affects them all. At least 9 themes characterize the families of alcoholics, and these also resemble those of families of other substance abuse users. First, the abuser's alcohol use becomes the most important thing in the family's life. Second, family members strive to keep the family together even when conditions are deteriorating due to the abuser's behavior. Third, family members often act as enablers for the abuser's alcohol use. Fourth, family members often feel incredible guilt and think they are at fault because the addict keeps denying their responsibility. Fifth, family members often feel out of control. Sixth, family members do not know what they want because their lives are centered on the addicted individual. They only know what the addict wants. Seventh, family members feel worthless. They feel no one cares for how they feel or for what they want. Eighth, family members do not trust others. They have been disappointed so many times by the dependent person's behavior that they cannot afford to dream about things getting better. The final one and the ninth one is the family members have poor communication skills. They learned a long time ago the credo of the chemically dependent family: don't talk, don't trust, don't feel. They do not talk to their friends or other family members. The effect of alcoholic parents on their children. That research indicates that children can often be deeply affected by parents who have alcohol use disorders. Variables such as family configuration, length of time that children are exposed to the alcoholic, and availability of a surrogate parent, such as an older sibling, a close relative, or neighbor to provide alternative support, can affect the consequences of alcoholism on children. Not every child of an alcoholic is doomed to become a dysfunctional adult. However, the risk of experiencing difficulties in childhood, adolescence, and adulthood are increased as with any other serious early encounters with trauma or deprivation. Children of people with alcohol use disorders must be involved in the treatment process, including being the recipients of individual and group counseling. Okay, our role in intervention with people who have alcohol use disorders may include maintaining an awareness of the problems involved, include also related information in the assessments we do regardless of our practice area, and making necessary referrals for treatment interventions elsewhere. Treatment approaches for alcoholism. There are numerous treatment approaches to chemical dependency to help people resolve their problems. Remember we talked about in Highlight 7.10, like detoxification, outpatient, and all that. There are at least 4 principles that have been deemed important regardless of the treatment approach. Our program first is engagement with a social worker in a trusting and open relationship where we engage clients as partners in the treatment. Second, we utilize a multiple system approach to develop an individualized treatment plan with the client. Third is follow-up care after primary treatment is ceased, and that's critical to maintaining progress. Fourth is clients need help in developing a social network of people or groups to call upon for support, guidance, and recreation. That one's very important. This network helps them maintain control of their gains by providing social and recreational outlets that replace key elements in a lifestyle that was sustaining abuse and dependence. The book discusses a 4-stage recovery model, and the first, that's an approach to alcoholism treatment that maintains that dependency involves an entire lifestyle. Therefore, to recover, one must abstain from drinking alcohol entirely in order to establish a healthier, substance-free way of life. The following 4 steps are involved. Stage 1 is abstinence, and this can last up to 2 years. The major focus in this is avoiding mind-altering substances and acknowledging that relapses are fairly common. Stage 2 is confrontation, and this is lasting up to 5 years. And this is where clients begin confronting and changing the personal, the family, and the social issues that contributed to their chemical dependency, to their chemical dependent lifestyle. They learn how to conduct adult relationships, they assume responsibilities for their actions, and they explore lifestyles that do not include drugs and the people associated with their chemical dependent past. Stage 3 is growth, and this usually is occurring after the 5 years of abstinence. This phase involves beginning a new lifestyle, not involve alcohol use. And the final stage is the 4th stage, and that's transformation. And this stage involves a true change in life orientation from the former alcohol-using days. The person has established new social networks and personal skills to live life and thrive. Alcohol no longer has a place in this new existence. And that's the 4-stage recovery model that the book talked about. Alcohol and other substance abuse still. We're talking about the strengths perspective on alcohol abuse and dependence treatment. Harm reduction is a treatment approach that emphasizing means to reduce the harm caused by the addiction. The harm reduction approach provides more flexibility in terms of treatment planning and goals. It also stresses how clients have the strength to assume responsibility for changing their behavior. A client may choose to establish a steady controlled consumption instead of total abstinence. The worker does not force clients to place labels on themselves. Rather, the worker assists clients in understanding the costs of drinking and exploring what options they have to gain greater control of their lives, if that's what they desire. There are 5 helpful tips in harm reduction. There are 5 helpful tips in the harm reduction approach, and that's highlight 711 on page 299. The first one is to express empathy. That means be warm, respectful, and accepting of that individual. The second one is to develop discrepancy, meaning we need to help our clients to find the discrepancies between what they are doing and what they prefer to do. The third is to avoid argumentation. We do not try to persuade, confront, or argue to clients that they are in deep trouble and would be much better off for giving up their addiction, because this turns many people off. Fourth is that we roll with resistance. We roll with resistance. That means we go with that reluctance and that ambivalence. We accept it. It's understood as a natural part of the change process. Fifth is we support self-efficacy. That means we support people's confidence that they can change by removing the false idea that we as the counselor would change them. We have to let them know that that they can, that they have strong in us, and it's all up to them. Other issues that we're talking about, we're going to talk about early screening for abuse and dependence, and that involves information concerning the pattern for use. There are examples of questions that can be used to seek the necessary information on page 300. And some of those questions are: what drugs have you used? How old were you when you first started using? and that's early screening for abuse and dependence with our clients. We talk about the problem of denial. It is suggested that the denial be addressed gradually, and we use a non-blaming manner when confronting the individual about the consequences of their drug and alcohol use. Then we talk about what if our client has a relapse. We acknowledge that relapses are common. There are 3 suggestions for how to frame the experience, though, to make it a positive one. First, we remain calm and we be empathic. Second is that we treat the ordeal in a beneficial light as possible. We emphasize what the client learned from it and how the experience can be used to avoid similar situations in the future. Third, if the relapse was related to stress, we address how to manage stress better in the future to avoid resorting to alcohol for relief. The next one is, what if our client arrives drunk? Counseling cannot proceed effectively, obviously, if the client is intoxicated or high. The main goal should be to minimize the disruption and to send the client home safely, and that being whether it's in a taxi or with someone else. Our client should not drive, of course. We should never place ourselves in jeopardy, though. We need to try to remain in an area where others are and we're with that client because they're unpredictable. Unless we don't know how that client is when they're high or intoxicated a lot of times. Now we're going to talk about empowerment at the METSO level. At the METSO level, we'll fill 2 roles, and that's when working with alcohol or other substance abusers. We'll make assessments and subsequent referrals to self-help groups such as AA, and we'll work with the abuser's family. Treatment of the family system will focus on family dynamics, communication, and change. The goal will not just be absence for the affected family member, but also improved functioning for the family unit as a whole. Empowerment at the macro level would be macro issues concentrated on how abusers in general are treated and on what solutions to substance abuse problems society proposes. They could focus on at least 3 major areas. The first dealing with the adequacy or effectiveness of treatment programs. Second macro issue involves the accessibility of alcohol and other substances to abusers. A third macro issue concerns prevention of alcohol and other substance abuse. As I end this lecture, I've got one question I'm going to leave you with. One critical thinking question is, what might be the best methods to stop alcohol or other substance abuse problems before abuse occurs? Think about that. It's been a long lecture. I hope you enjoyed it. I hope you took lots of stops and steps and breaks during it. I wish I could have.